talking about tuberculous uveitis, which I think is where we get the most questions. And I hope you'll develop some understanding of the limitations that there are in establishing a convincing diagnosis of tuberculous uveitis, and we'll talk about treatment. But the practical objective is that I hope that you will all have a little more information to sort of figure out what strategies your clinic will be able to have when you get these referrals from the ophthalmologist for patients with eye disease and a positive tuberculosis test. So we're going to start with a case from our clinic, which is the Camden County or the Southern New Jersey Regional Specialty Chest Clinic. And this is a person we saw last summer. He's a 60-year-old from the Philippines originally who was referred by his pulmonologist because of concern for pulmonary TB. His history was 3 to 4 months of unintentional weight loss of about 35 pounds, 3 to 4 weeks of a mildly productive cough, some left pleuritic chest pain, some increasing fatigue, and 2 weeks of fevers and night sweats. His pulmonologist had done a CAT scan, which was abnormal, and had actually ordered AFB smears, which were reported as positive, and he was sent to our clinic. When we first saw him in the clinic, let's see, this once again does not seem to want to advance. Oh, here we go. On presentation, he had a history of diabetes and hypertension. He had some chronic pain and swelling of his right knee that was being evaluated at the local orthopedic hospital. He had a positive tuberculin skin test back in 2007 with a negative chest x-ray and did not receive treatment for it. Does have a strong family history of a grandfather who had TB when he was growing up. He's HIV negative, no liver disease. He's originally from the Philippines, lived in Kuwait for a while, went back to the Philippines, and came to the U.S. in 1994, but does go back and forth to the Philippines every year to visit family there. His physical exam was notable for a weight of about 131 pounds, which is about 35 pounds under his baseline. He was low-grade febrile. He had good vision in both eyes, but was colorblind and had a little bit of redness in the right eye. He had crackles in both lungs, and he had some mild swelling of the right knee that was not warm. And his labs are shown here. He had a little bit of renal insufficiency, an elevated alkaline phosphatase, and a very high sedimentation rate. And this is some images from his CAT scan, and you can see this sort of diffuse, almost miliary-like pattern throughout all of his lung fields. All right, so at that time, he was started on treatment in the clinic because suspicion for TB was so high. We requested the films of his knee that had been done elsewhere because we were somewhat worried that this could also be related to his tuberculosis. And then he returned to the clinic 3 weeks later and was already feeling better. His cough was improved. He gained a little weight. His knee was about the same, but his eye he had increasing redness and some pain in his right eye. And in retrospect, he's not much of a complainer. He actually had some pain on the first visit that he didn't mention to us. His vision was unchanged. His pupil was reactive. And by this time, we knew that his sputums were already growing Mycobacterium tuberculosis. His liver enzymes were stable. His uric acid was elevated. All right. So with this presentation, here's our first question. So does this patient have ocular TB disease? And here's a couple of choices. Yes, no. We need an ophthalmologist to tell us, or there's other testing that we can order from the clinic that might help with that decision. So just any thoughts, you can type them in the chat box or unmute yourselves and let me hear what you think.
Thanks, Henry. So this case at least is diagnosed, certainly diagnosed as at least pulmonary or disseminated TB. And the question you're bringing up is, does this include the involvement of the eye based on his complaints?
Okay, so I think that by inference, we all probably think that this could be TB disease of the eye, but it could be something else as well and coincidentally related. And obviously, we're not ophthalmologists, so our feeling was that he obviously needed to see an ophthalmologist to help us with the diagnosis. And so let's move on. He saw the ophthalmologist who the exam as documented describes panuveitis, and the diagnosis of the ophthalmologist was granulomatous uveitis. He was started on corticosteroid eye drops. He was not started on any systemic steroids, and there really wasn't any notation of what the ophthalmologist thought the etiology was of this. And then we saw him again in clinic 3 weeks later. This is now 6 weeks into treatment, and he's continuing to do well. He's gained another 9 pounds. His shortness of breath is better. His energy level is improved. His right knee still bothers him, and now he's got severe bilateral shoulder pain. But at least his eye pain is better, and the redness of his eye is better. And his retroorbital headache that he forgot to tell us about on the last visit, which he says was really bad, has now improved. And we now know that he has pan-susceptible disease. Okay, so would you do anything different now? So does this diagnosis, does his eye exam fit in with a diagnosis that this is related to his tuberculosis? And do we have to do anything different in terms of his management? All right. So I think that at this point, we were pretty comfortable that his eye disease was related to his tuberculosis. And we moved forward with his treatment. I think had we known about his headache on the prior visit, we might have considered a lumbar puncture. But at this point, the headache didn't seem to be an issue. So we considered it, but we opted not to. Because of his high uric acid and severe joint pains, his PZA was actually stopped a little bit early at 6 weeks. And his ethambutol was also stopped because we had susceptibilities. And he continued to have get steroid eye drops and have ophthalmology follow-up. And his clinical course, he sterilized his sputums after a couple of weeks. He gained 30 pounds. He's back at work. Interestingly, his knee symptoms ended up resolving completely, and I suspect they may have been TB disease as well. His steroid eye drops have been slowly tapered, and I think just a couple of weeks ago, he finished his 9-month course of treatment. Next slide, please. All right, so this just shows you his chest x-ray, which remember had that diffuse miliary type pattern, and at 6 weeks was clearly improving, and by 8 months was almost completely resolved. All right, so this brings us back to our previous question. So did this patient with extensive pulmonary TB and probable TB osteoarthritis of his knee also have ocular tuberculosis. So that's what we're going to talk about today, is ocular TB. So part of the problem with the diagnosis of ocular tuberculosis is that we are not ophthalmologists. Next slide, please. And this creates a bit of a language barrier. We don't necessarily speak the same language that ophthalmologists do. They focus in on a very small universe and have a lot of terminology and know the anatomy of the eye, and most of us are much less adept at understanding sometimes what exactly they're talking about. However, there's some important terminology that hopefully will clarify this a little bit. So this is a picture of the eye, and this is the outer eye here in the upper left side of your screen, the stuff that you can see. And then the lower picture is the stuff on the inside. And most of the TB disease that we'll be talking about involves the uvea, except the uvea is actually not just one structure. It is this layer of the eye that's located between the sclera, which is the outer layer that you can see, and the retina, which is what we look in people's eyes to look at in the back. And the uvea actually consists of the iris, as the ciliary bodies, and the choroid. So when ophthalmologists talk about some of the diseases involving the uvea, they actually give you a little more information. Uveitis is sort of the general term for any inflammatory disease that involves the uvea. When they talk about anterior uveitis, that involves the front of the eye, and most commonly that's iritis or inflammation of the iris, but can involve some of the other structures as well. Intermediate involves this middle section, usually the ciliary body, and then posterior uveitis involves the choroid and the retina and includes chorioretinitis. They also use the term panuveitis when they're talking about uveitis that involves all different layers of the eye, okay? Now, they use another term called granulomatous uveitis. And unlike when we talk about granulomas, where we actually use this as a histopathological term, this term is really based on their fundoscopic of the exam of the eye, and they use it when they see these large, greasy-looking keratotic precipitates that are characteristic of granulomatous uveitis. Next slide, please. All right, so how does TB get to the eye? Most of the time, we believe it gets there by hematogenous spread, but it can also get there by exogenous infection. It can spread directly from infection involving surrounding tissues, or it's postulated that it also gets there by self-contamination from the sputum, although I know this is sort of difficult to prove. There are also immune, presumably non-infectious syndromes that probably cause some of the TB disease we see in the eye. And there's sort of a blur between what component of disease is actually just inflammatory response to the TB antigens, like we sometimes see in other locations, and what actually is due to direct infection from the organism. Next slide, please. So TB can involve the external portions of the eye, the lid, cornea, sclera, and conjunctiva, which you can generally see. It can also involve the tear ducts. Most commonly, however, it causes uveitis and can involve the uvea in all of the different locations we talked about. TB can also involve the retina and cause a retinal vasculitis, and can involve the entire eye as well. And occasionally, but less commonly, TB can involve the orbit. Next slide, please. All right, this is just an example of what TB iritis or anterior uveitis would look like, where it involves sort of that, where you might have visual signs that you can see the inflammation surrounding the eye anteriorly. Next slide, please. This is actually not a patient with tuberculosis, but it was a good representation of when we talk about granulomatous uveitis. You get these kind of cloudy looking precipitates in the eye. They've been described as mutton fat deposits. They kind of look like splots of grease in there. And these are the criteria that an ophthalmologist would look at and say, this is granulomatous uveitis. And sarcoidosis can present in a manner very similar to tuberculosis. Next slide, please. This is an example of somebody with choroiditis or tuberculous infection of the choroid with lots of these, all of these little white spots are small foci of choroiditis in the choroid in a patient with panuveitis. And next slide, please. Or occasionally, rather than multiple small choroidal lesions, you can see one large choroidal lesion, and this was felt to be a choroidal tuberculoma. And the next slide shows you what happens after they treated it, and it was left with residual scarring, but the lesion itself has resolved. Okay, next slide. So how common is TB uveitis, and why we really aren't sure about exactly how common this is? The numbers that you see there are actually from the CDC's reporting data for extrapulmonary tuberculosis cases and site of disease, and you can see that TB eye disease does not make the list there, and that's for a couple of reasons. One is most cases of TB eye disease are never definitively established, and we'll talk a little bit about what constitutes a case. The other problem is that even in people that we treat for TB eye disease, are these cases actually being counted as cases of tuberculosis? And the ones that seem more definitive, like the first patient that I presented who clearly had pulmonary disease and almost certainly had TB disease of his eye, he gets lumped into the category of disseminated disease. So the fact that he had TB disease involvement of his eye doesn't get picked up in these kinds of reporting statistics. So we can look at this another way. Can we have the next slide, please? All right, so how do we diagnose a uveitis case? Well, like the first patient that we saw, you can present with eye signs and symptoms and have TB disease at another site, either pulmonary or extrapulmonary, and you're making the diagnosis by implication. Now, some of those people can have other coincidental factors that cause their eye symptoms, and occasionally some of the medications we use can cause eye inflammation. Particularly, this is a toxicity that's been reported in patients who are on rifabutin with certain other medications. But most of the time, if they have eye disease that develops coincident with their tuberculosis, that's a pretty good idea that that's related to TB. However, that's actually the minority of patients who have TB eye disease. Most patients with TB eye disease present with eye signs and symptoms and are diagnosed on the basis of a positive test for TB infection. A small number of those will actually go on and have diagnostic studies from their eye, but the vast majority of them are just clinically diagnosed. Next slide, please. So how common is ocular tuberculosis in patients who have TB disease at other sites? Well, there's a bunch of studies in the literature. This is one particularly well-done study that was done in 1997 in a Spanish hospital, where they actually did formal ophthalmologic exams of 1/3 of the 300 consecutive patients who were hospitalized with confirmed tuberculosis. Now, this is a bit of a selected population because, one, they were hospitalized, and two, a high number of them were HIV positive. This was back when the HIV epidemic was raging and before we had effective antiretroviral therapy. And at least in this cohort, which is probably a sicker and more immune suppressed than average cohort, they reported that 10 had probable and 8 had possible TB disease of the eye with a variety of different manifestations. Now, this number is kind of high. Next slide, please. And this just shows you a bunch of different studies that talk about how often patients had ocular manifestations in the setting of TB at other sites. And you can see the numbers are fairly variable, but the numbers range from about 1.5% to much higher numbers than that in some of the studies where patients are more immune suppressed. So it's at least 1 to 2% and maybe higher. Next slide, please. Now you can look at this the other way. Instead of looking at how often people with TB uveitis, how often TB is implicated as a cause of uveitis, rather than looking at how often people with TB end up with eye involvement. And this is a much more difficult question to answer because there are many studies in the literature, but it depends on where in the world they were done, at what time period they were done, and what diagnostic criteria were used to establish a diagnosis of TB uveitis. We know that in developing countries, infection is a cause of up to 30 to 50% of cases of uveitis. And in most of the world, TB is the most common, but certainly not the only infectious cause. However, in developed countries, uveitis due to autoimmune disease, post-traumatic, and idiopathic are far more common than infection. And this just shows you some representative studies taken from all over the world in terms of the percentage of cases of uveitis that were seen at various institutions and the proportion that they felt were attributable to tuberculosis. Okay, next slide, please. All right, which brings us to our next two cases. Patient 2, and these are much more typical of many of the referrals that we actually get to the clinic. The second patient was referred from a local eye hospital for treatment of TB chorioretinitis. He's a 68-year-old US-born male, history of a positive tuberculin skin test when he was incarcerated back in the 1970s. He did take some pills for a while, but he never finished treatment. He's had 6 years of visual symptoms in both eyes, worse on the right, but his symptoms have been worsening over the previous years. He was initially diagnosed with macular degeneration, but didn't seem to respond to treatment for that, and was referred to our local eye hospital. And in the local eye hospital, they found bilateral chorioretinitis with severe vision loss on the right, but worsening inflammation on the left. And this was their diagnosis in their notes: infectious, syphilis versus Lyme versus other inflammatory processes. And they sent a battery of infectious tests, which is sort of the standard workup for uveitis. He had a positive RPR, but at low titer with a negative FTA, but he was quantiferon positive and had a negative chest X-ray. They sent him to their local infectious disease group for treatment, but the ID specialist there said he doesn't need treatment. There's no indication he has TB. And then he was sent to his local health department here, who referred him to the regional clinic. All right, and this is the note from the eye hospital. I put this in the talk just so you can understand that we're all equally unsure about what to do with these cases. They said, if evidence of TB would likely require treatment, but if no evidence, still strong suspicion for TB chorioretinitis, and will need to work with ID on treatment that is least hepatotoxic. If ID remains concerned about hepatotoxicity, and if they believe suspicion for TB is low, they could consider steroid injections into the eye. Okay? So to me, that's not very helpful, because they're asking me if I believe that he has TB infection in his eye. And I'm not sure I'm any better at telling that than they are. Next slide, please. All right, so this was his visit to the clinic. He was a very healthy appearing 68-year-old, no history of TB, but known positive skin test in the past and now a positive quantiferon. He previously treated hepatitis C, drank fairly heavily. His eye exam is listed here. His chest x-ray was negative and his baseline liver enzymes were negative. All right, next slide. Okay, here we are. So does this patient have ocular TB disease? All right, and what would you do now? Should we treat him? Should we try and get some samples of his eye fluid to make the diagnosis? Or no, he doesn't have ocular TB disease. Any thoughts?
Yeah, Henry, this is Jim Sundstrom from Michigan.
Hi, Jim.
Hi, this is a great presentation because we've been very interested in this in Michigan. So this patient has many of the classic risk factors for TB, having history of incarceration, and that puts him at significant risk for TB. You certainly can try and get an aspirate of his anterior chamber, but takes a bit of work and effort with the ophthalmologist. But I don't know if that has much of a yield.
Okay, and I'll actually show some data on that, but it's you have to convince the ophthalmologist to do that, and they're not super enthused about it, and the yield, as you say, is not great. So I think, so the next question is if you're going to treat him, and I think that there was sort of no way to not treat him, what kind of a regimen would you use? And I will tell you, there is no definite answer to this, although, and I'll show you what the ophthalmologists do a little bit later on as we discuss some of these things. But we opted to start him on a standard regimen. We actually opted not to give him ethambutol for two reasons. One is the presumption was that his TB was acquired a long time ago, so we were less concerned about resistance, INH resistance, and also we felt that we could not effectively monitor him for ethambutol toxicity with his severe baseline visual impairment. So he completed 2 months of INH, rifampin, PZA, and then 4 months of INH and rifampin, and he actually did quite well with his treatment regimen. According to his ophthalmology notes, his eye inflammation stabilized, whatever that means, but I think it's way too soon to tell whether or not this had any significant benefit for him. And we'll talk about that's one of the challenges is how do you know whether or not your treatment works? Okay, so this is another patient. This actually came in as a call from upstate Pennsylvania. And I think that this came from Erie, from the TB program up there. And it was one of a couple of cases that they had discussed with me during the past year. This was a 60-year-old woman from Sudan who had 5 days of left eye pain and blurry vision. She also reported that she had had a similar episode about 5 years previously that got better on its own. And in addition, she has history of well-documented treatment for latent TB infection back in 2004 and was diabetic. On her eye exam, she had inflammation in the left anterior chamber and was diagnosed with acute iridocyclitis and was started on steroid eye drops and had a battery of tests. I list them here just so that you can see this is sort of the standard battery that an ophthalmologist would send in a patient with presenting with undifferentiated uveitis. Next slide, please. All right, so her inflammation got better, her steroids were tapered off, and her lab work essentially was remarkable only for a positive quantiferon TB gold test with a negative X-ray, no symptoms, and good documentation of prior treatment for latent TB infection back in 2004. All right, so what would we do with this patient? Should this woman be treated for TB eye disease? Or would you treat her differently than the patient that we just talked about?
Well, Henry, this is Jim again. Yeah, I would treat this person for TB eye disease, item number C.
Okay, any other thoughts? I see, Al, you also would treat for TB eye disease? Okay, so let's move on. So here's the question. Did either of these last two patients have TBI disease? Do both of them have TBI disease? So now we're moving on from our first case, who's somebody who had TB and eye disease, and we're pretty comfortable with the diagnosis, to people who have eye signs and symptoms, positive TB tests, and eye disease. And so how do we approach these patients? Well, none of us are ophthalmologists. I don't think there's any ophthalmologists in the conference. So we're going to ask some anyway. So, hello?
Yeah, go ahead, Henry.
Okay, so let's move on to the next slide. All right, so I put up this article because this just sort of, the title of it, I think, explains how controversial this is amongst ophthalmologists. There's controversy about the terminology, there's controversy about how they make the diagnosis, and there's controversy about treatment. So I think what this tells us is just like we and ophthalmologists don't even speak the same language, ophthalmologists amongst themselves don't all speak the same language either. So I don't expect you to read this slide, but this slide comes out of a systematic review of ocular tuberculosis treatment that I'll be talking about momentarily. But you can see all the permutations and combinations that can go into making a diagnosis of somebody who has eye findings that are suggestive of tuberculosis. So basically, it's complicated. Next slide, please. So I said we were going to poll some ophthalmologists. We don't actually have to do that. Somebody else did it for us. This was a survey that was sent to members of the American Uveitis Society, who are the people who obviously are most specialized in treating uveitis. They sent the survey to and got responses from about half of their members, most of whom are in North America, but 23 who are in other regions of the world. They presented some case scenarios of a patient with pan-uveitis just to take the pulse of what ophthalmologists would do and how they would manage these people. And the responses really varied quite widely on a number of issues. And we'll actually look at some of their answers in a second. Let's move on to the next slide. All right, this just shows you what tests would prompt them to consider treatment for presumed or possible ocular tuberculosis. Now, case one was somebody who presented with granulomatous panuveitis and had no specific TB risk factors. And case two was essentially the same patient, but somebody that the history said had just moved from an endemic TB area. And interestingly enough, that whether or not they came from a TB endemic area didn't matter that much to them in terms of the data they looked at and what they would use to make a decision. And you can see that in many of them, a positive TB test alone is enough to treat, and they're a lot more comfortable with, at least in foreign-born individuals, quantiferon or T-spot testing than skin testing. Next slide, please. All right, and this is some true-false questions that they were asked about, and I do want to point to the last one. So you can see that almost only in the minority of cases will they ever try and obtain ocular fluid for a diagnostic study, okay? So the expectation that they're going to try and get fluid from these patients is actually pretty low. So the fact that most of these patients don't have a diagnostic test shouldn't be surprising to us. Next slide, please. This just shows you the range of answers in terms of how long they would treat the patients. And the bottom line is that they would never treat for less than 6 months, because I don't think that they would think that there's a way that you can really tell if a clinical trial is helpful at 2 months or 4 months. So they would, I think, once you're in for a penny, you're in for a pound. Once you start treatment, you're going to go ahead and give them a full course of treatment, however long that may be, whether that's 6 months or 9 months, or even 12 months in some instances. All right. So getting back to Jim's question about making a specific microbiologic diagnosis of ocular tuberculosis, we know historically that the yield of AFB on smear and culture of eye fluid is quite low. And in part, that may be that not all of these are due to active infection. It may be in part due to the fact that this may be paucibacillary disease, and it may be due, in fact, in part due to the fact that you can't really get a whole lot of eye fluid to culture. So the samples that you're working with are quite small. But whatever the reason, the yield on AFB culture is from the eye itself is quite low. However, a number of studies have looked at molecular techniques in terms of diagnosis, and most of these studies are actually reported from an ophthalmology group in India who have a large number of patients who go to vitrectomy for uveitis. They also have a large number of controls who go to vitrectomy for other reasons unrelated to concern about tuberculosis. So when they looked at GeneXpert, the sensitivity was only about 25%, although the specificity was quite good in patients who they had a clinical diagnosis of ocular TB. When they looked at the new version of the MTB-DR Plus line probe assay, that performed a little bit better than the GeneXpert, but still only a minority of cases were positive. And they also reported data on their own homebrew multiplex PCR for tuberculosis, which actually performed better than either of the other two tests. But you can see that with the commercially available testing that we have, the majority, and from an endemic area where tuberculosis would be much more common than some of the other causes of uveitis, the sensitivity in suspected cases was pretty low. Next slide, please. So then the next question is, if they have TB uveitis, do they get better when you treat them? So do we have actually good outcome data on what happens when you treat people with anti-tuberculous therapy for TB uveitis? So there have been many retrospective case series that have been published, but they're widely there's a lot of heterogeneity in these studies, in the population, in the diagnostic criteria that were used, and most of these are uncontrolled studies. However, there has been one recent systematic review that actually looked at these studies and did a meta-analysis, and I'm going to also talk about one brand new retrospective clinical cohort that I think will serve as the basis for this work going forward. Next slide, please. All right, so this is the systematic review and meta-analysis. Uh-oh, my computer just logged off here, so give me 1 minute to log on. Because I have no screen at the moment. Okay. All right, so this is that same study that had that very complicated flow diagram that I showed a few slides ago. And they looked at 28 different studies, which included about 2,000 patients. Some of these studies had control groups of patients who only got systemic steroids but did not get anti-tuberculous therapy. But most of them were uncontrolled studies. And their outcome that they looked at was non-recurrence of inflammation after TB treatment, whether or not they got steroids. And the relative risk of an 84% of the people who got treated with anti-tuberculous therapy got better, but so did people in the control groups who didn't get anti-tuberculous therapy. And the relative risk of improvement with TB therapy in the small number of studies that actually had a controlled group was not that dramatic. You were 1.42 times. Your relative risk of getting better was slightly higher than in the people who didn't get anti-tuberculous therapy. Only a couple of trials reported adverse drug reactions, but not surprisingly, about 10% of people had to stop their TB therapy due to toxicity. Next slide, please.
And Henry, can you just stay on that slide for a second?
Sure.
So this question comes up in our clinic as well about non-recurrence of inflammation. And some of these patients do not have acute uveitis or eye problems, but chronic eye problems. So it may not improve, or they may have chronic inflammation. You know, the eye is kind of an immune sanctuary, and there may be, you know, TB antigens deposited in the eye that could cause chronic inflammation. So this is one of the arguments we have, is if you have recurrent inflammation after treatment, does that mean recurrent disease or not? So that's just a comment I want to make.
Right, I think that's absolutely true. I mean, that's why we don't really know always what we're doing when we're treating these patients. Next slide, please. Okay, so this just shows you from that meta-analysis the why of these 28 studies, all of the different how TB, ocular tuberculosis, was diagnosed. Usually it was a combination of methods, but you can see that only a small number, or 6 of them, they actually did ocular investigation, and most of them it was exam, systemic investigations like chest x-ray, blood tests, and exclusion of other etiologies, and in some they used response to anti-tuberculous therapy, but some people got better without it. Next slide, please. So the last slide study I'm going to talk about is actually one that was just published in December in JAMA Ophthalmology, and this study was actually done by the same folks who did the systematic review and meta-analysis that I just showed. It's a large multinational study, including studies from Asia, but as well as some studies from North America. And they tried to use fairly consistent diagnostic criteria. And these are the diagnostic criteria they used, which were clinical features consistent with TB uveitis, exclusion of other common causes, and usually that's on the basis of history and other laboratory tests. And then they either had to have positive TB test from somewhere else or directly from the eye, or a positive IGRA or tuberculin skin test or a chest x-ray that looked like old TB. And they had to have been followed for a minimum of a year to get some sense of whether or not they relapsed, because that's often an important criteria, although what that means we're not always sure. Next slide, please. All right, and you can see that in this cohort of patients, most of them did not have any symptoms suggestive of systemic TB at the time of presentation, although a higher number did have history of tuberculosis at some point in the past, either pulmonary or extrapulmonary. Next slide, please. And this just shows you some of the diagnostic tests that were used. And the bulk of the patients, the diagnosis was made on the basis of positive skin test or T-spot or IGRA testing. Next slide, please. So what were their conclusions? So they actually, the most useful thing about this study is that it actually gives you a large cohort of patients who they think had TB uveitis using somewhat standardized definitions. Of the patients who were treated with anti-tuberculous therapy, they said they considered about 1/8 of them, or 12.5%, to be treatment failures. And the things that predicted a higher rate of treatment failure include having panuveitis, which maybe it's a marker of more severe disease, if they had bilateral disease, and I didn't mention that, but probably about half of these patients with TB uveitis, in fact, have bilateral disease. And when you look at these studies, they not only talk about the number of patients, but also the number of eyes that they're evaluating. And this study is important because I think it provides the basis for a lot of the ongoing work that's being done, because clearly this is a topic that has attracted the attention of the ophthalmologists who are trying to approach this in a more standardized manner. Next slide, please. All right. So I also want to briefly describe actually a more complicated case, but this case is being presented just to show you the flip side of what we've been talking about. This is a 34-year-old Chinese-born woman who was referred for treatment of presumed TB uveitis. She had onset in April of 2017 of blurry vision and redness of her right eye, no eye pain, but a mild right-sided headache. She saw her local ophthalmologist. She was given steroid eye drops, didn't get better, and was actually started on systemic steroids, but continued to get worse. She was seen at our local eye hospital. And during this period of evaluation, this is what the exam described: anterior and intermediate uveitis in both eyes, with some thickening of the iris and the choroid, worse on the right. Next slide, please. She really had no significant past medical or surgical history. She had her laboratory evaluation was notable for a positive quantiferon TB gold test and a negative chest x-ray, and was given a presumptive diagnosis of TB uveitis, and was referred to the local health department for treatment, who then started her on treatment and referred her to our regional clinic. Next slide, please. So when she was first seen, she had been started, I think, in the prior week on RIPE. She had some fatigue, but no other symptoms. Her eye symptoms were not improved. She continued to have very blurry vision on the right and some eye pain. And in history, she'd come to the US in 2000. She had no known TB exposures. No prior TB testing had been done. And this was her exam. Her liver enzymes were pretty unremarkable. The rest of her labs were pretty unremarkable. Next slide, please. And this just shows you a chest x-ray and CAT scan. The CAT scan was done because she actually ended up in a local emergency room the day before she came to our clinic with some swallowing and choking symptoms, and ended up getting a chest CT, which didn't show anything, and a CAT scan of the head, including the orbits, didn't show anything either. Next slide, please. All right, so she was continued on her TB therapy. 3 weeks later, she's not doing so well. Her weight is down. She has worsening daily headaches. She's nauseous and vomiting after taking her medications, which she points to the PZA as being the culprit. And her eye symptoms are unchanged, and her last ophthalmology exam reported increasing inflammation, and she was also noted to be mildly icteric, and her medications were held, and here are her lab results from that day. You can see that she has a bilirubin of 2.8 and very elevated transaminases. Next slide, please. All right. 1 week later, she returned to the clinic because they were very concerned about her. She's not feeling any better. Her eye exam is unchanged. Her transaminases are improving. However, her bilirubin is higher. So what do we do now with this woman who has what we think is TB uveitis, had significant evidence of what looks like drug-induced liver injury from her medications, but also has worsening headaches and still has nausea and vomiting. So what would you do with this woman now?
That's a tough one, Henry.
Yeah.
I think I would probably go with B for now.
Right.
Jim?
Okay. Any other thoughts? I actually did not see her in the clinic, but she was, I mean, the people who saw her were very concerned. And within the next week, she did end up in the hospital. Next slide, please. All right, so she started to have increasing headaches, confusion, slurred speech. She had a rash, which somebody thought was consistent with disseminated zoster. She rapidly deteriorated in the hospital. She ended up intubated. Her liver enzymes had actually continued to improve by this point. She got head imaging that showed irregular thickening of the anterior chamber of the right globe and cornea. And an abdominal CAT scan at this time showed large bilateral adrenal masses. Next slide, please. So obviously there was concern about meningitis. She had a lumbar puncture done. There was 21 white cells, a mixture of polys and lymphs with a mildly elevated protein, normal glucose. And she continued to worsen over the next 2 weeks. She was started and stopped on a variety of anti-tuberculous medications. I'm not going to go through all of those. Her liver enzymes and her bilirubin worsened and did not do well, and unfortunately, she ultimately died. However, next slide, please. The cytology from her spinal fluid and her final diagnostic studies showed that she had a natural killer T-cell leukemia, and her involvement of her eye was probably also due to her NK cell leukemia, which has been reported to cause uveitis in a number of cases. So the reason I present her is this is somebody that gets stamped as TB uveitis, and not everyone that we treat for TB uveitis actually has tuberculosis. She may have had tuberculosis infection, but her uveitis certainly was probably due to something else. And in fact, her TB treatment could potentially have delayed the diagnosis of what her underlying disease was. All right, next slide. So let me present some conclusions, and then I'll open it up to any comments that anybody has. So what do we know? TB can affect the eye in a variety of ways in patients who have either pulmonary or extrapulmonary disease, but the most common manifestation is uveitis. However, more commonly, TB can cause uveitis in patients whose only indication of TB is a positive test. The diagnosis is usually made clinically, and most patients do not get PCR or culture studies of eye fluid, but even if they do, the yield is relatively low. Among ophthalmologists evaluating these patients, the decision of how and when to test for TB is variable, although most academic ophthalmologists will include TB testing in their evaluation. There are some clinical features that I didn't dwell on that are more associated with a diagnosis of suspected TB and response to treatment. If you go back to the third case I talked about, the woman from Sudan with the anterior uveitis is less commonly associated with tuberculosis. Also, patients who get rapidly better and don't relapse are also less, with traditional treatments like steroids, are also less likely to have TB disease than ones who are refractory to treatment. In many of the studies, TB uveitis does improve with anti-tuberculous therapy. However, many of these patients are also treated with steroids, and we don't have a lot of control groups to say how much of the benefit comes from TB therapy. The treatment regimens and duration are not well defined, and there's really no guidance on when we should be making a more aggressive effort to establish a microbiologic diagnosis, especially in patients who might have higher risk of drug resistance or higher risk of toxicity. The good news is that I think this is a diagnosis that is receiving more attention among ophthalmologists, and perhaps this is the reason why we are getting more referrals to treat these patients. And I think that better communication with the referring ophthalmologists and the people who are actually treating their TB disease is really essential to try and optimize their management. Okay, the next slide just has some references. And then we can open this up to any questions or discussion.
Thanks so much, Henry, for a great presentation. I think I'm not the only one who will say that some of the confusion has been clarified, at least from our side, the TB clinician side, from your presentation of various cases, as well as the review of current evidence. I am glad to hear that there is a lot of work going on looking at this topic from your reference list here. They are more recent over the last 5-10 years, it seems, for most of these meta-analysis, so that's good. I think we need to look at these issues a little more closely. If any of us who are listening are to take anything out of this, what would your advice be with regards to patients that are presented to us with this diagnosis? How would you put that in one sentence? Is it reasonable to just go ahead and treat and move on? Or should we persist in further workup? How would you sum up our approach based on what you know?
I think making sure we understand why the ophthalmologists think that this is tuberculous eye disease, and what their database is to make that, what they actually see in the eye, what their workup has been, and whether or not they've had response to therapy, or, whether this is just a checklist diagnosis, or whether they really think based on their clinical course, this is a likely diagnosis. because you have to balance that against the risks of treatment, which are not trivial. I mean, in that last patient that I presented, she clearly had significant drug-induced liver toxicity, even though she didn't actually have tuberculous uveitis.
Exactly.
So that's why I think the communication is, it can't just be the ophthalmologist say, send them for TB treatment to the local TB clinic. They have to be responsive to us when we ask these questions. I mean, I think it has to be more of a partnership than it seems to have been in many of these cases. So.
And I think just using the fourth case as an example, I think for most of these cases, it should be almost a diagnosis of exclusion. You know, there are many other causes of uveitis, as you mentioned, and I think due diligence to rule out other potential causes should be part of the workup. I was wondering if you came across from your meta-analysis any frequency of sarcoidosis in the diagnosis, or at least in the groups that looked at?
Yeah, sarcoidosis in the developed in the studies from developed countries is actually probably a more common diagnosis than tuberculosis.
Mm-hmm.
But then again, that's a reflection of the patient population too. But sarcoid is among, that's why, you know, an angiotensin converting enzyme level is part of the evaluation, is part of their, you know, checklist evaluation of anybody with granulomatous uveitis that they see.
Oh, okay. For those who have comments or questions, please press *6 if you're on the phone to say something or have a question. Anything from you?
This is Jim Sundstrom again. And Henry, I have to thank you for doing a wonderful review, especially updating us on the recent literature, because in Michigan, we've been following this topic for the last 2 or 3 years, and we've been working with our state TB epidemiologist to make sure that any case that comes to the state that's called uveitis or iritis or granulomatous inflammation or episcleritis, we lump those together as ocular TB cases. And when we started to do that, we recognized that over 10% of our active TB cases in Michigan could be counted as ocular TB. And we did a poster last year at the TB conference that we were up to 14%. Now there was a lot of pushback about that, because, you know, people said, well, those could be autoimmune, or they could be sarcoid, or they could be something else. So what we did as a control group was compared the demographics of the ocular cases with the demographics of our culture-proven pulmonary cases, and the demographics were identical in terms of foreign-born percentage, in terms of U.S.-born people with history of risk factors like incarceration or substance abuse and so on. So I think there's growing national interest in this unrecognized diagnosis of ocular TB. And I know, Al, we saw another poster from Oregon this week at the National TB Conference in California, and they were reporting 8% of their state cases are now categorized as ocular. But this does require collaboration with your epidemiologist to lump all these cases together properly.
Right.
Yeah, and I think that's why they've been almost invisible cases, and I think that probably even more of these than most TB cases are probably treated out of the health system and are treated by private ID specialists because and they never get counted at all. because there's no culture data, there's no microbiologic data, it's all clinical.
That's right.
So some of these have been treated as latent tuberculosis with autoimmune uveitis, and I think that could be a mistake.
Yes, that's the other angle. Is there are probably a subgroup of patients that actually don't even get counted because they're subjected to latent TB infection treatment, and they just go along and have the same presentation. So I think we're moving in the right direction, though, with this discussion and review of the literature. I again appreciate your presenting this topic to us. I think if we could, this is definitely the first time it's been so well discussed without the help of an ophthalmologist. So thank you, Henry. I think if there's no other pressing question from those who are on the line, we are going to have to close the meeting. It's 1:10, and thank you again for participating this afternoon. And again, thank you, Henry, for presenting this to us this afternoon. I'd like to just announce to the group that next week will be another interesting TB Grand Rounds, which will focus on genitourinary tuberculosis, and we'll have a presentation from Virginia with resource persons joining in on the topic. So join us next Friday, June 1st, for another interesting TB Grand Rounds. And for everyone else, please enjoy the long weekend. For those in Jersey, I might just see you down the shore. Thank you, everyone. And Henry, thanks, and have a good weekend. Bye.
Thanks all. Bye-bye.